of you who are joining us today. I'm really excited about this webinar, Integrating Patient Safety and Clinician Well-Being. As David mentioned, I'm Elisa Arispacochaga, Vice President of the AHA's Physician Alliance, and I'm really pleased to have Dr. Michael Privitera, who is the Medical Director of the Medical Faculty and Clinician Wellness Program at the University of Rochester Medical Center, and a good friend who I've known for a number of years doing this work on well-being since as I like to say, before it was even cool to think about well-being. So I'm really excited to have Mike join us again, and also Kate MacNamee, Senior Human Factors Engineer and Director of Design Research at Ximedica. Ximedica. I'm excited to hear what they have to share with us. I've been following their research for a while, and I just think it's some really neat stuff. So without any further ado, I'm going to turn it over. Mike, I believe you're going to get us started.
Yes, exactly. Thanks so much, Elisa. It's a pleasure to be here with you all, and we'll have some time at the end for questions. But I thought I'd give you a few background issues of why we're getting into what you'll see some of is actually human factors and ergonomics in use in healthcare, and more to help leaders actually. So it's a really step back from the usual application of human factors and ergonomics, but trying to see if we can come up with ways that leaders can learn some that might be helpful in their decisions, eventually to help prevent latent medical error and clinician burnout. So we hope this will be interesting to you. So when a lot of this happened, like as Elisa said before, it was cool to look at this about clinician burnout and safety, trying to make sense out of what the plight, how the plight could be explained for what's going on. We feel we're overwhelmed. We know it's not safe, but how can we come up with language and some kind of science to make sense of it all? And looking into this for a while, because when you're starting a new program in wellness, it's good to be factual and can't be emotional about, even though we're all overwhelmed. So the sciences seem to make the most sense about human strengths and limitations as it's been used for pilots and air traffic controllers and astronauts with NASA, with human factors and ergonomics approach. Basically, ergonomics is the study of people's efficacy in their working environment. And what is so great about human factors, it seems like the perfect science for us because it optimizes work well-being and overall system performance. So the worker well-being is kind of married to the overall system performance, which is exactly, I think, what we need. And that patient safety is part of optimizing the system performance. So we'll talk a little bit about how this can actually mitigate and prevent conditions upstream. So I'd love to introduce you to Kate. She and I were both presenting at International Symposium of Human Factors and Ergonomics in Healthcare, March of 2019, Chicago, when we used to be able to travel. So with that, I'll turn it over to Kate.
Thanks so much, Mike, and thank you all for your time. So I'm very passionate about this topic, and I think that the audience here hopefully is too. And really, I think Mike hit it on the head. He really hit the nail on the head with this one, that our whole goal of this presentation is to help hospitals and hospital administrators understand how they can leverage patient safety and clinician well-being together, and how they can optimize and basically understand that cognitive resources are something to be budgeted. Just like time, just like personnel, just like money. So today, the questions that we're hoping to answer are, what problems continually occur in clinician brains across hospital systems, and how do those problems in the brain affect them personally and also potentially affect their delivery of care and the quality of care they can deliver. We're also looking to understand what are the underlying or root causes of those issues in the brain. So what are the things around in the environment, and what's the workload that's maybe causing deleterious effects on cognitive functioning. And we're also looking to understand, how can hospital leadership and administrators address these issues within their scope of decision making. So we understand there's a reality around this, right? You can't go and tell JCO exactly what they should and shouldn't regulate. But there is and can be and must be strategic implementation of metrics, and quality standards to ensure that we're not overburdening clinicians and to ensure that we're aware, at least, of what we do implement and how it affects the brain. So, before we even go into the details of the what and the why and the how, just some key points for you to think about as we go through this. Clinician brain power and neural resources is a limited resource, just like gas in your car. Highly trained resources, and they can be budgeted for most effective use. So the idea of if you know that you only have a few miles left, you should really be prioritizing and helping these clinicians prioritize the way that they're spending those resources. In this case, getting to a gas station for the metaphor, but if you're very low on cognitive resources, you better be focused on the patient, their safety, and the well-being of the care that you're providing. Second, emphasizing healthcare assessment, safety and quality has been quantifying, metrics and trying to get to implementing as many safety protocols as possible. But really, we're missing the opportunity to say, are these really effective, and can we reduce root causes further upstream at the implementation of metrics, policies, and procedures. Third, there's a lot of unnecessary cognitive load on clinicians simply because we're trying to put in as many possible procedures because they're all well-intentioned, right? None of us are going in saying, let's implement this safety procedure so we can really stick it to the clinicians. But that's actually what ends up happening in some cases. And so, implementing a quality metric that has no tangible effect on quality of care or patient safety or even, the business case for the hospital, those sorts of things can really have a negative effect on the clinician well-being and therefore the safety of patients. And so it's important for us to help, as hospital leaders, it's important that we understand, okay, what about basic human factors and ergonomics that I may not have trained in? How can I understand those things to help me make better decisions for the hospital as a whole? Clinician burnout and latent systemic causes for medical error can be reduced with use of tools that we discussed today. And with that, I'll hand it back over to Mike.
Okay, super. The World Health Organization defined burnout, as you know, in the ICD, was it 10 or 11 maybe? Burnout is a syndrome conceptualized as resulting from chronic workplace stress. It has not been successfully managed in the three dimensions that we're pretty familiar with, but energy depletion and exhaustion, increased cynicism, mental distance. This is what starts to affect the experience of care for the patient. And then reduced professional efficacy. In the beginning, you think you're not as good as you'd like to be, but as burnout continues, you actually are not as good as you usually would be. And then Krasinski is, in the AMA, she's discussed this. Burnout is usually related to a mismatch between workload, resource, and resources needed to do the work in a meaningful way. So some of us, if you've been seeing a lot of talks on clinician burnout, but there's three major rounds, right, where the impact is institutional, patient effects, financial effects, personal effects. In terms of institutional, medical errors can go up 200% the more severely burned out a person is. Malpractice claims disruptive behavior is related to this. There's a change in the irritability, cynicism, reduced empathy for patients, their satisfaction goes down. And actually, when you're giving a prescription, the adherence to that treatment regimen goes down the more the people are burned out. Satisfaction scores goes down. This translates into finances, turnover costs. If you self-insure, 114% increase in medical claims by your own employees. Short-term and long-term disability costs go up. Suicide rate, tragically, in physicians, 400 a year expected. We had a number here when we started this wellness program, and thank goodness we haven't for a while. We're very grateful for that. Substance abuse, divorce, coronary heart disease, it's kind of dose-related. The higher the burnout, the higher the risk of heart disease. And career satisfaction, which is highly correlated with patient healthcare satisfaction. So medical error and clinician burnout, the systemic contributions are what in common. IOM report 1999, error is human. The majority of errors in healthcare are results of systemic influences. And we've been able to study that occupational stressors causing burnout are predominantly the result of systemic factors. So there's something big in common. So some of the quality paradox that Kate has alluded to here, too, is that many of the well-intentioned interventions for quality, safety, or value, when taken in total, because there's so many and from so many sources that don't necessarily collaborate with each other, it contributes to healthcare system dysfunction by the cumulative impact on workload and burnout. A nice study that was done over time, just in the workforce, stress at work, every decade you can see that using the same instrument over time, stress has been going up at work. And recently, a great study by Elizabeth Terry and others, and Kristinsky was part of that. The higher the cognitive workload, the higher the risk of burnout. This was a study done at University of Rochester, where I am. The higher the clinical FTE component of that person's job, the greater the burnout. But of great interest was the factor that most sustain the sense of meaning is patient work. So that seems like a paradox, but when you think about it, our calling of going into medicine is trying to do what you were called to do. So what are the major problems? What we learned from the write-in responses of the survey were enormous amount of volume of obstacles to delivering care, and that also leadership was unaware of the burdens clinicians experience. So here enters human factors and ergonomics. If you take a look at the slide in terms of all the dimensions of science that contribute to the field of human factors ergonomics, just to point out organizational psychology, educational psychology, clinical psychology, cognitive neuroscience. So we're going to be spending time on cognitive neuroscience and how that applies in the organization. So there'll be a little bit of both. So basically, it's optimizing human well-being and overall system performance, as mentioned. Patient safety is a component of good system performance. And this is something that I hope to get more and more towards. What a HFE practitioner is looking for is fitting the system to the people instead of fitting people to the system. A lot of things for like our electronic medical records, the terminology used, we have to get used to that terminology as opposed to fitting into the way we think as clinicians. So examples of systemic contributors to burnout, latent error. So thought it'd be useful to kind of give examples just so, and we'll be trying to show ways of helping to deal with this. So what you see as an administrator or as a leader, prescribed work. So it looks pretty manageable on paper. So you're starting up the office, warming up the computer, patient arrives, pre-meeting for finances, waiting room, giving the forms for the patient, nursing takes vitals, EMR records, review, doing your clinical work, writing orders, labs, notes, and diagnosis and billing. Well, let me introduce you to the term shadow work, which is, it's from a great book by Craig Lambert, who's a Harvard sociologist. Unseen, unpaid jobs that fill the day, creates additional mental effort and infiltrates workflow and practice. So to show you just some examples, this is a real practice that always did not happen at the same time, but they all happened. So some of the things you're trying to start seeing the patient, it's too hot, it's too cold, there's a crack in the window, the wind's coming in, lighting, the bulb is flickering, warming up the computer, you have trouble with the software, you have to be on the phone with IT, clinician-based forms not given, the EMR forms, as you know, it's been set up more for billing, not as much for clinical practice. Trying to see the patient, make sure you don't make any mistakes, but then is writing orders the way, like an example, like if you're trying to order a Depakote level, it will not come up in the orders. You have to find exactly the right form to get the order. So that spends a lot of time and frustration, or your password expires. There's all kinds of things like that, basically, that are unseen, that accumulate, that aren't really seen to top leadership. But it's experienced and seen down below by the clinician. So this is making the point about triple aim as we've come out in healthcare reform, and now a lot of call for the quadruple aim. The importance of the experience of providing care is that quadrant that's below in kind of a yellow. This is more important than we may realize because a lot of people that are in healthcare that support the industry do not have direct experience with providing care. And if you're building an EMR, you don't. Or if you're doing other kinds of technology, you don't. So it's important for guiding technical device companies, regulators, legislature, et cetera, who may not have that experience. So that's the call for a national framework that we can all agree to. And it's more important, basically, if you look at that experience as human factors in the delivery of care in particular. And that if that's kept in the C-suite, then more things are more likely to be thought of to help make the practice go better. So an example of what NASA does, they have a cognitive load measurement. And look at the things that have the greatest weight. Mental demand has a weight of 3. Temporal demand, how quickly you rush, 5. Effort, 3. Frustration is even in there at 3. And so why does that become important? Because it affects your cognitive capacity, which is limited. Even highly intelligent people can reach their cognitive load very quickly. And even your best staff can create medical error because of the cognitive load that's too much. So an example of using the NASA TLX in a study, it was done in 2010, showing the higher that cognitive load, the increased risk of medical error. This is kind of keeping in mind because a lot of things, our whole premise is that human limitations has not been included enough in healthcare reform and healthcare delivery to understand what is the maximum, how much is too much, that the expectations are. So when we talk of stress, it may get confusing because, isn't healthcare a stressful occupation? Well, there's hypostress, which is too low of a stress, you're bored. The eustress is the stress needed. Sometimes it gets us to do well on tests. Then too much goes to distress, and very high stress is hyperstress, past which there's a rapid decline into breakdown, death, or suicide. So realizing this is the average human, and that's the important piece of human factors application in healthcare. We have to keep these things in mind. Some of this work here is from Krasinski and her collaboration with Brian Arndt at the University of Wisconsin. But this is the plotting of the EMR usage in the time of day. The blue is during the week. This brown is on the weekend. And as she points out, calling this date night. This is 9 to 12 midnight. So a lot of work is done here, work outside of work. Some people call it pajama time documentation. And because it's electronic, you can do this at home. So there's a blurred boundary between work and home intruding. And studies suggest that at least physicians 10 hours or more per week interacting with the computer. And what does this do? We did a study at Medical Society State of New York, how burnout goes up, job stress increase, satisfaction goes down if there's excessive regular EMR documentation at home. And the risk of burnout goes up 46%. And something to know, just because we're in the human club, that if you start working over 40 hours a week, your brain efficacy goes down to 35%. So what does that mean? That the same thing that in a regular work week you could do, it takes you 3 times as long after you've worked that long. And how does this intrusion affect burnout and the person's relationships? A lot of the things with healthcare, if you're a clinician, you're salaried, the institution may not be aware of anything outside of work units like RVUs or whatever completed. And they may not be aware of when and how long it takes to get the work done. So there's not a lot of managerial pressure to suppress that work because it's costing the institution more. But in the meantime, because there isn't any feedback system like that, clinician performance and personal lives continue to suffer. So this is the longer the time you're awake, what happens to your your performance in those hours I was showing you about pajama time, your performance starts to decline, almost like you're drinking more alcohol. And what happens in your relationships, studies done through the Mayo Clinic, work-home conflict, the greater the work-home conflict that is doing work-related issues at home, you're not with your significant other, family, your kids, the risk of burnout doubles, the risk of depression doubles, and seriously considering divorce goes up almost double. So the mechanisms behind burnout and latent medical error, wanted to switch back to Kate.
Excellent, thank you. So, we're talking about this idea of burnout. We're saying that, there's a well-being problem for clinicians, nurses and physicians alike, technologists, but that all those terms can feel very abstract and kind of squishy, if you will. So I want to delve into the actual underlying mechanisms and talk about, what's the cellular cause of this, what are some of the behavioral causes, and what does that mean for you to make it a little bit more real, right? So first, technological advancements have already surpassed human cognitive adaptation. We evolved to make technology, and then technology surpassed our evolution. So currently, we are already well above, our cognitive needs to be able to interact with technology on a long-term basis. So that's why all of the screen time, all the Zoom time, remote working from home if you're privileged enough, those things in the pandemic have increased quite a bit. But in general, our brains are not ready. They've not yet evolved to be, screen-only mechanisms. They're not computers, even though we often create allegories with computers for them. And so it's important for us to realize, what's happening here. So technology will continue to outpace us. It results in increased connectivity, tracking, accountability, and expectations. And those things improve or increase cognitive load because there's this pressure that at all times you must be present with someone or something that isn't present with you. And that social psychology and cognitive psychology alike, that type of use of resources of the feeling of always being monitored and a continued sense of responsibility continues to drain your resources even when you're not at work, when that connectivity happens. So technology costs are low and personnel costs are high, which means that from a business perspective, the more we can decrease staffing and increase automaticity, that's great for a business, but that typically tends to mean that the remaining staff left are trying to, hoist a much larger load cognitively and physically as they navigate the space and try to complete the tasks that normally a greater number of people would be doing and manage the technology that maybe isn't, perfectly designed to fit human cognitive capabilities. So this idea that technology is quite often very functional. Engineers do an amazing job of keeping things, working correctly. But if no one can use them and no one can interact with them very easily, suddenly all the shadow work of troubleshooting is greatly increased. And then also with this idea of technology, when you have so much to do and so many different things, that it normalizes deviance in the culture of a hospital setting. So this idea that it's like, well, we all know we can't do it all, so you know what, just start choosing the things that you're not going to be able to do. Make sure you just skip the right things. But of course, when your brain is really overloaded, your prioritization and decision-making are very poor. And so at a cognitive level, whatever you choose to drop may not be the best thing to drop, and that sometimes is something that could cause an error or lead to decrease in patient care. So a little bit of a step back to the basic science here. Cognition can be controlled or automatic. So controlled is like when you're paying attention to something, and automatic is kind of when you're not. Controlled thought uses up cognitive resources, and in this case, we're mostly talking about glucose. There's oxygen, there's ketones, there's all sorts of things, but really the primary fuel of the brain is sugar. So automatic thought conserves resources, burning far less glucose. So the more our brain can leverage automatic thought, the lower the resources that we're spending are. And so, it creates what's called cognitive economy, this idea that our brain is trying to be automatic in as many situations as possible while still completing a goal. However, automatic isn't always great. Just because it doesn't use resources doesn't mean it's going to be accurate. And so when incorrectly applied, an automatic process in a novel context, that's when you get your medical errors. And so the more, the lower on resources you put your clinicians, the more cognitive load and more tasks they have to remember and navigate and deal with, then the more likely they are to try to do something automatically inappropriately, leading to that error. So when, I want to make sure, again, we're talking, these aren't abstractions. We're talking about neural structures and cellular functions. Your controlled thought is in the prefrontal cortex, the neocortex, so that really, this is the most highly evolved piece, and therefore it's the first to go when we're trying to conserve resources. So we're talking about limited and expensive neural resource here. It's used for high-level functioning like decision-making, prioritizing, diagnosing, and then, needs restoration. So the idea that if you need to be away, you need to have a break, you need to be able to take a step back and let your brain refuel that area so that it can function appropriately. Whereas automatic thought is more in the basal ganglia and the amygdala. So you're talking about habitual memory, low neural resource, and so because it's quick and automatic, but again, not necessarily considering context and nuance, that inexpensive thought is what comes to the forefront when you're overloaded. So if you think of your brain as a car and glucose is the gas, there are things that would drain your resources and use up a lot of gas. In this case, excessive workload, whether it's physical or cognitive or even emotional, which is cognitive ultimately. Goal maintenance, so updating working memory, making sure that you regulate yourself. So that could be not going off on a staff member who's made a mistake. That could be dealing with a patient in the family and dealing with the emotions there and trying to keep your emotions at bay, inhibiting fear and anger, coping with bad outcomes and grief. Focusing attention on anything, so decision-making at any scale, sorting and classifying, task switching, so when someone bursts in the door and asks a question in the middle of your case and then they leave and you have to get back to that case, that's burning up a lot of resources. Similarly, resolving cognitive dissonance, right? So lack of organizational resources and feelings of unfairness or saying, no one's listening to me at work, also conflicts with the face of this, well, I want to be a good worker and I need to, perform to a certain metric. And so not feeling you have the support and trying to say, well, this is a good cause and I'm going to go and do the right thing anyway, those things, even just that decision-making process takes a lot of energy. On the other side is replenishing tasks. So what helps refuel clinicians and humans in general? Well, sleep, which we know when you're on call you don't necessarily get a lot of, or you're actually doing double 12s to fill shifts, snacks and meals, which can be, few and far between during your shifts, time away from screens, walks, particularly in nature, have actually been shown to restore cognitive resources faster and allow for a greater event-related potential to waves that are associated with attention. Mindfulness and meditation, work satisfaction or, achieving a goal can kind of give you a reward, and sometimes those rewards will also, in the ventral tegmental area, improve, cognitive resource acquisition, time with friends and family, spiritual practice. All of these things are important for clinicians and people in general to restore their resources. And so when people talk about work-life balance, they're not just talking about, oh, you do some work and you have some life. It's really about making sure that there's a clear boundary between them so that when you're at work, you're not making mistakes and performing poorly. So to bring this home, really, there's this idea of cognitive load. And cognitive load is in 3 different categories. So there's intrinsic load, which is, your brain needs to function in order for you to wake up, walk around, and breathe. There's what's called germane load, or what I would say task load. So the load required to do a task. And so there are lots of complex tasks in medicine. And so some germane loads will be greater than others. If you are let's say you're working in a vascular surgery and there's an emergent need for intervention during the case, then that's a very high germane load because your goals are very strict. There's a lot of emotions going on, all sorts of things that you can't avoid, right? So we're not saying, you shouldn't make clinicians think, because that wouldn't make sense either. But what we are saying is because oftentimes in medicine, both intrinsic and germane loads sum to a much higher point in the cognitive, the cognitive spectrum of capacity, that any extraneous load, which is load that could be designed away, essentially, load that can be removed, whether it be with more thoughtful and strategic implementation of metrics, decrease in shadow work, better medical devices, more intuitive software, and even more streamlined workflows from an NSOP standpoint. Those things can take away extraneous load. And the reason you want to take away extraneous load is that once you cross this threshold of cognitive capacity, demand exceeds your resources, you're going to go to that automaticity inappropriately, and errors are going to increase greatly. And there are a few things that happen here. So one is, again, you go to automatic thought. Automatic thought often leads to load shedding as well. So offloading information, first low risk and then random, because again, you can't think about what you're thinking about when you can't think anymore. And that it sounds ridiculous, but it's one of those things where we're not good at metacognition. And so we're not even aware of the importance or lack of importance of what we're choosing not to do. We're just not doing it anymore. And finally, goal shielding, I should say, so not allowing new information into the brain, not responding to appropriate environmental stimuli. I won't go through this in too much detail. I want to be conscientious of time, but I think that, I want to be clear that burnout's effect on cognitive function. So over time, there's lots of stress, long-term cognitive load is high, and over time, that causes that burnout problem. And so when you're constantly under a high cognitive load and you don't get to refuel your resources, that's when burnout occurs. And burnout then has this really vicious cycle, because the things that created the burnout are also the things that burnout causes. You're not good at task switching. You can't be interrupted and still be accurate. You're not as good at updating your information with changing environments. Burnout, it literally decreases, neuronal functioning in the brain and actually can kill cells because of the inflammation and stress that it causes. And so when your cells are dead, you're no longer able to have as strong an inhibitory response to maybe an annoyance or a frustration or an emotional problem. You're not good at paying attention to things when you're burnt out. And that can happen over time, really creating biopsychosocial changes that are not permanent necessarily, but very hard to reverse. You're not good at memory, working memory, manipulating information, all these things that clinicians need to be on their game with. You're over time, if they're burnt out, these things are going to get worse, and that perpetuates more burnout because you're making more errors and you're more stressed because you can't perform at your best level. So this is kind of that cycle that we have. And this is what I was touching upon. There are hormonal changes, there are genetic changes. You can see excess glutamate, neurochemically speaking, so leading to decrease in gray matter, and that's in the basal ganglia. So even in your automatic processing, you're going to have decreased fine motor control, but you're also going to have decreased automaticity. So again, we're looking at pathways in the brain that are being negatively affected, potentially for the long haul. And then neuroanatomically, you see thinning prefrontal cortices. You see enlarged amygdala, so hyperreactivity for emotions, fear, fight or flight, endocrine systems, and then hippocampal shrinking. So again, you can quite literally see on scans a decrease in the structure that's responsible for memory and encoding, or at least partially responsible. So I want to talk through a little bit of this. I think this is actually Mike, so I might hand this over to you.
Okay. Thanks, Kate. Basically, this is a connection of that dilemma between is this burnout or is this major depression? Well, the issue is burnout is a work-related phenomenon, and we should be thinking about burnout, and that major depression is personal health information. It's PHI, but it's highly correlated that the higher the level of burnout, the higher the risk of having a major depression. So burnout, using that term, and then we always see, is that something people feel comfortable talking about? Seems like more so now that at least among clinicians you can talk about being burned out, and it gets to be a target that we can actually improve. So it's a work-related condition, combines job strain and a high occupational stress. Major depression is clinical, and it is meant to be confidential unless the information is meant to be released. But the important thing here is that once you get into a major depression, it affects your cognitive functioning, verbal, nonverbal learning, a short-term working memory, visual auditory processing, problem solving, motor function, and processing speed. So there's probably some overlap, but the idea that major depression even then gets to be affecting us even in different ways. And the horrible thing about it is major depression, once you have it, it's about a 50% chance of occurring within 5 years if it's your first episode, but if you had 2 of them, it's like 70%. And if you get 3, it's like 90%. So now we're complicating what's happening at work with affecting us personally again. So what can leaders do? So I think starting to understand the structure of patient safety issues and how we integrate that into the delivery. what the implementation of a lot of metrics, of a lot of mandatories. So looking into this more, so all the information we just presented kind of gives us a way of looking at some of the traditional models for error and prevention. How do we account for the burden of non-strategic barriers that actually thwart good care? So we've all learned in patient safety about the Swiss cheese model of James Reason. And by putting in various systemic barriers, we can help prevent this problem from occurring where unfortunately, the holes in the layers and the barriers line up and the error occurs. So that's what a lot of barriers are trying to do. But I think what we need to do is be selective, because to some degree we've had kind of Swiss cheese on steroids to some degree with mandatories that are more than what we could possibly do. So let's look at this model that we have to be able to balance. How can we balance this? They need to be strategic. There's potential unintended consequences that you don't want to thwart care. But looking at one of the slices in the idea that to some degree, if it's not strategic, excellent care can be thwarted. So we have to be very careful, and especially about how many things we're asking the clinician's brain to be doing. As far as like a urinalysis, can that be given as a verbal order instead of the person having to stop, write the order, et cetera? So we have to realize how to work with the brain, that we're trying to be very careful and safe, but there's a flex point where it gets to be more dangerous. So let's look at trying to put together a model. How can we understand this piece here? Because that's a new piece. So we put together a model of understanding excellent care, provision of excellent care, but barriers to care, thwarted care. So there's acute effects and there's chronic effects. Chronic effects is what Kate has begun to talk to you about. There's cognitive deterioration that can occur either in an acute way or sometimes neuroanatomically now or chemically, where the cortisol's too high and then too low. So there can be a deterioration, a devolving of the capacity to give good care, average care, poor care. But we still have good barriers here, the great defense barriers that'll be good catches and near misses and preventing the incident from occurring. So our work here is to try to provide a model that we can include the downside so that you do things in a way that you try to balance it. So this would be handing this back over to Kate to kind of give some of the background about safety interventions.
Excellent. Thank you so much. One of the things that I think is one of if you take nothing else away from today's talk, put your phone down, stop looking at other emails, and focus on this, which is knowledge and skill, like training, is one of the biggest solutions that medicine has focused on as a way to prevent patient safety issues and medical errors. However, if you look at the root causes of underlying medical errors, 87% of them relate to cognitive load. And so really, there's no amount of training that can train a person to have a higher cognitive capacity. No matter what you do or how much you teach them, you can definitely create increase in automatic processes, and you can make them more expert. But again, when you have a high cognitive load, the clinicians will inappropriately apply those automatic processes that you trained them so well on. And so that's where your training and skill and knowledge work really doesn't do the job. If you look at attention on task, information processing, and critical thinking, those types of malpractice issues and medical errors, that is affected directly by cognitive load, and that's when people that have a decreased cognitive load that they make errors related to those things. Then if you look at noncompliance and normalized deviance, those are two things that result from being overloaded, and those are basically choices people make to shed the load and randomly and kind of non-strategically and with uninformed cognition say, oh, I can't do that today, I can't worry about that, it's just too much. And when that happens, that also, again, goes right towards those medical errors and issues. So if you look at the difference of the 12-13% that knowledge and skill can help versus the 87%, the real solution here is to be designing better procedures, better workflows, and better devices in the hospital environment so that you can really mitigate those use errors on a more substantial level. And if you look leadership, really, if you look at the system level causes of the things that would increase, cognitive load or, have poor skill or training, all of these things are wonderfully, in many ways in control of hospital leadership. And that's why we're so encouraged and so excited about the talk today, is that, the structure, the culture, the processes, the policy and protocols you implement. I know there are certain things and regulations that cannot be avoided, and we have a lot of empathy for that. But even the technology and the environment, what you choose to buy and why you choose to buy it, and how the environment facilitates or impedes workflows, those types of things are all based on, human factors and cognitive ergonomics and regular ergonomics. And so if you have human factors professionals in your hospitals and you hire them to help you streamline these things, that's when you can actually take a huge chunk out of that 87% of root causes for medical error. So I talked a little bit about this vicious cycle earlier, but to bring it home again with the, what can you control? Because again, we can't control everything. We can't control society or regulatory guidance, but we can look at all of these sort of mitigable negative environmental factors. So if you look at the orange up here, you have things like, care that's been thwarted by, again, barriers that are kind of needless, or metrics that don't have a true effect on safety. High workload. In this case, we're talking physical, cognitive, and emotional. A lack of cognitive restoration, so that increased connectivity and no culture of avoiding work or separating from work. Untested metrics and requirements, so those sort of indiscriminately implemented procedures, and then poor medical device design. All of these things contribute to high cognitive load for clinicians, and thwarted care in particular contributes to acute stress directly. And so what happens with acute stress is that over time, many acute stress instances cause chronic stress, and chronic stress also adds to that high cognitive load. High cognitive load then decreases cognitive capacity, so that's sort of the filling up of the capacity and reaching that threshold of, overreaching your cognitive capacity. And cognitive deterioration from stress also reduces your capacity. So at this point, you have clinicians who just don't have the resources to perform at their best. And these are some of our highest trained professionals in the country. And they're not able to do their best because they're being set up to fail by a system that isn't thinking about their brain, because they're like, they're so intelligent, they don't need this stuff. You have some defense barriers that can create those good catches that Mike alluded to, but oftentimes the barriers just aren't enough because they're being shed, and that's when medical errors happen and decrease patient quality of care. So this flow chart is a really great way to see the clear relationships and the things that that the medical and hospital administrators should be able to address in order to sort of remove some of the catalysts of this cycle. So how can leadership make a difference? We've now come to you with all these problems. Problem. But, we also want to offer solutions, because if we just sat here and said it's not working, that's not very helpful for anyone. So, Mike, is this you or me?
Yeah, this is me.
All right, all you.
Okay, thank you. Thanks, Dirk. Conventional thinking versus integrated thinking. This is really the key. And this was based on the study by Martin about how successful leaders think in Harvard Business Review. So what is conventional thinking? It's basically obviously relevant features. Often it's choosing between A or B, or finding that, or thinking that, okay, one thing A created an outcome B, then more of A must mean more of B. Well, that happens a lot with a lot of the mandatory laws, regulations that are meant to be helpful, but to realize there's that crossover point where the graphs start crossing. Integrative thinking is kind of using what we're talking about today to give you those tools to be able to see there might be a downside. So where's our control? The control is that implementation, how it's implemented. Where's our control? What are our options when it's implemented? That's where integrative thinking comes in. How to creatively resolve tensions among what seem to be opposing ideas and getting innovative outcomes. A new idea may be better than either of the choices. So how do you implement patient safety metrics, mandates, laws in the context of preserving clinician well-being and functioning, better weighing these risks and benefits? So kind of introducing you to this idea. of these two types of thinking. And why is that important is that into the study that most successful leaders studied were integrative thinkers. So that's in general as being a leader. How do you do this? So what we hope we did is give you some tools and some science to help with this. This is looks like a complicated slide, but let me walk through it. This is the fourth thing, the experience of providing care in more detail, human factors and ergonomics and care provision. So from the national, state, local industry, there's requirements, and these come down pretty much as conventional thinking. Here we are at the hospital level administration with all the offices, quality and safety, finance, compliance, billing, info management, mandatories, medical staff office. So the idea here is the code or the color might help. The yellow plus blue, at least in grammar school, would become green. So the clinician input and collaboration being key. How do you get the input that we know these things need to be done? We need to keep the lights on. We need to comply to survive. Can they be adapted a little bit in a way that is allowing you to be able to get them done and not be as overwhelmed? That's where the integrative thinking comes in. So that's the point of this slide. Setting up ways, and I'll show you a little bit about how we try to build in structures within the institution, within the medical center, that gives regular input from clinicians that then can be adapted at this level to make it more user-friendly. So realizing and remembering that the work environment is the healing and safety environment. So the work environment, how do you make that better so that the healing environment is safer? This is critical. So broad stroke interventions for reducing cognitive load, evaluating processes, standard, and by the way, as you know, I think Elisa will say, you'll get copies of these slides, but we just want to kind of introduce you to the top level things. Standardizing things, but not at the cost of safety, but doing it deliberately, thoughtfully. Consolidating, how do you bring processes together that are related to each other? That's the whole idea of what a dashboard is. It's bringing all these different features into where your working memory that only has about 20 seconds of processing can look at these things and make decisions. Decreasing redundancy, prioritize design and with layouts and deliberate designs that consider this. Have human factors professionals. One hospital in Toronto I heard of had 5 HFE engineers. Our hospital doesn't have any yet. We hope we're going towards that. But the things that Kate does, and I'm telling you, it's really critical to try to get that kind of language into your hospital. And so that by that, having the clinicians involved, like purchasing IV pumps, making sure that they work similarly so you don't make mistakes. That's the interface design, that kind of thing. This is an example of our mandates that we had. We put them all together. Here we had 38 that we came up with in the source, and here was like 84. Some of them overlap. But no single mandate is a problem, but taking together the sum and create, especially if they're coming from different sources, different offices, it's an enormous thing to keep track of that is wasted cognitive load. So how can you filter, manage, and streamline them? How do you standardize them? What's due? When is it? Who does it go to? What do I have to do to complete it? Use the same software so they're not learning new software for everything. And then what we call satisfactory and sufficient to meet requirement, but have, for example, voluntary things that you can learn. You have mandatory, but have the information is important for a reason, and that's why we're asked to do it mandatory, but is all of it needed for the requirement? How much can you call up in the clinical situation that might be helpful to build a resource? So an intervention case study, here's a initial steps in a wellness program. 2 things, a lot of places do secondary control, which is how to adjust to remaining stressful situation, but primary control is fix the problems causing the stress. So we try to do both. The individual things are mindfulness-based practice, 3 good things, gratefulness journaling. We did a lot of wellness seminars, had to count for continuing education, malpractice reduction. Organizational, whether bottom-up or top-down, it's good to have it as a combination with participatory management. Any of these in blue, feel free to email me and I'd be happy to give you more detail about it. And Kate will have her email there too at the end. How to build in structures. We have a strategic wellness planning work group that we cover a lot of these things. Senior leadership involvement, strategic times, brief presentation so we're all on the same page. The assessment is, like we did a well-being index, is what we use to get a burnout score, but the write-ins are really very helpful. What gives you most meaning? What are the major stressors, and what are the reasonable suggestions that you come up with? Make it anonymous in the beginning so you can get past the culture of concern about what people think about what you write. And then other things you can do is have, once you have that data, you can present it together in a group, the aggregate data, using the Vegas rules. Forgiving hierarchy relationships, what happens in Vegas stays in Vegas, and you can later talk about what was talked about, but don't say who said it. And so this is an ongoing process to be able to work on these structures. This would be just an example of what the write-ins were. Too many screening questions, can the patient's help? This data in the EMR is unintuitive locations. So anyway, this is basically a list. I won't go through it too much. Comparing lean and HFE, lean process, the focus is customer patient. Here's HFE includes quadruple aim. And ease of discussion, this is mainstream medicine. Here we're talking about the person themselves practicing and what would make their life better. Value of employee benefits, it's both in lean and HFE, but the employee lives the problem is a bit of a difference with HFE. Application, to mitigate existing problems, but leaders knowing this can actually apply concepts to prevent problems. That's a critical difference. So this is back to Kate, who will bring us to the close.
Excellent. So for the last few minutes, I want to walk us through a couple of examples of applications, things you can do in healthcare environments to solve for some of these issues. Very concrete examples, but these are not by any means comprehensive, merely examples. So one example is, the expensive activity might be, for a clinician, might be extraneous information processing, which is basically responding to or processing information unrelated to your primary diagnostic or procedural goals. Let's say that maybe like the required screening questions are unrelated to the patient's reason for the visit, so asking them about whether they've ever smoked when they're coming in for, let's say, wrist pain. The solution is, the patient entered data on the website or in the waiting room to save the clinician cognitive resources, so you can still collect this, valuable information, but it's not necessarily going to, gung up the workflow for the clinician themselves. Some other examples are, for goal maintenance and working memory. Let's say that a software design requires multiple pages and pop-ups to complete a task. You might implement software or buy new software that has dashboards that really create action pathways that are accessible from a single location. So we're talking now about software design. For those of you familiar with Epic, there's a lot going on in Epic, and there are different ways that information architecture could be structured in order to more cleanly facilitate these workflows. Similarly, maybe clinical data are stored in unintuitive locations. So rather than put that burden on the clinician, maybe you have a health information management team who's in direct collaboration with clinicians and can provide them that information without having that clinician search through folder after folder for possibly 20 minutes while they're trying to achieve their goals. See what else we have here. Interruptions and multitasking is a big one. I know they can't necessarily be fully prevented in hospital situations, but I do believe strongly that if we're going to allow people to function appropriately within interruptions, and the idea of multitasking, which is really just task switching rapidly back and forth. So a good example is, a nurse is interrupted while passing meds. Someone comes up with a question and they answer it and they go back to the meds. That shouldn't necessarily, it shouldn't happen with too much frequency. And so maybe the nursing medication room policy is implemented to prevent those kind of intrusions. Similar example, maybe a clinician is asked non-urgent questions from others during procedures. So they, this culture, creating culture of making sure that there are certain priorities. If the person's in the case, the only thing you would go in for is a more important or emergent situation rather than simply just an opinion. And then prioritization is another big one. Again, you'll have these slides, and so I urge you to read through some of these if you can. afterwards. But, busy work is sometimes conflated with virtuous work. So this is acknowledging that halo bias, right? So the idea that, there's a checklist that you have to go through of various paperwork and various things, as everything from warming contrast in the OR to, checking and double checking certain charts. So you got to make sure that you know what work is in fact preventing that those errors and improving patient safety. Like double checking the chart, probably improving patient safety. But warming the contrast, is that more about comfort? Is that something that's necessary? How do we go about deciding that? So using data-driven, studies and figuring out, if we do this and we don't do this, what are the different outcomes and does it change things? And really understanding how that affects both the safety and well-being of patients and also the well-being of clinicians and weighing those benefits and those risks. So you'll see slides like this. Another good one is negative transfer, right? If maybe a hospital purchased, IV pumps from multiple vendors, and key elements of their interfaces are different or they conflict. So if someone's used to, they've been using an IV pump for, for the last 15 years, and now they still have some of those that are still working, but they've replaced 4 or 5 with some new ones. Standardizing those and just transitioning completely over to the IV pumps that are new and retraining with a focus on combating negative transfer could decrease errors surrounding the use of that pump. So really just being aware of those types of changes and how you how you can use infrastructure to help clinicians transition from one tool to the next without necessarily endangering the process, the patient in the process. So thank you so much for your time. I want to be respectful of your time. If you have any questions, do reach out. But really appreciated everyone who was able to attend today, and hope to hear from you with questions and thoughts.
Thank you so much to both of you, and really appreciate the presentation. I know we're at the top of the hour, so both Mike and Kate's emails are there. We will be posting a recording, so if you want to go back and listen to something again, and as she mentioned, the slides will also be on our website, but they're also up in the resources tab. Very quickly before we finish up, I just want to mention one other factor, which they didn't talk about, but the importance of having leaders who are not burned out and the impact of burnout spreading. So we will be hosting a virtual resiliency program coming up May 17th and 18th. More information will be up on our website, and we'll be happy to share. But really value the all of the conversation about the impact on the cognitive load. And this can't just be about those at the front lines. We also have to think about how to support our leaders so that they are supporting our teams and we're all supporting each other. So with that, Kate and Mike, thank you so much for your time, and I look forward to continuing the discussion.
Thank you so much for hosting us. We really do appreciate it.
Absolutely do. Nice to talk to you all, and thanks for having us.
Thank you, ladies and gentlemen. That concludes today's presentation. You may disconnect your phone lines, log off the webinar, and thank you for joining us today.